മരണത്തെക്കുറിച്ച് ആലോചിക്കുമ്പോൾ എന്ന് വെച്ചാൽ മനുഷ്യനെ അത് തോന്നും, മരണം ഇങ്ങനെ മനുഷ്യനെ വരുന്നുണ്ടോ, പെട്ടെന്നൊരു ജീവൻ മനുഷ്യൻ്റെ ശരീരത്തിൽ നിന്ന് പോകുന്നു. അത് പെട്ടെന്ന് രോഗിക്ക് തന്നെ മനസ്സിലാവും, ഇങ്ങനെ പോകുന്നുണ്ട്, മരിക്കുന്നുണ്ട് തോന്നും. 2 മിനിറ്റ് കൊണ്ടും മനുഷ്യന് തോന്നും.
മരണത്തെക്കുറിച്ച് ആലോചിച്ചിട്ടുണ്ടോ?
ആലോചിച്ചിരുന്നില്ല. അത് മനുഷ്യന്മാർ ആരും ആലോചിക്കും, ജീവിക്കണമെന്ന് ചിന്തിക്കും.
We have thought about it and we know it is someday it is going to come. Definitely it is going to come.
അല്ല, എന്തായാലും നമ്മൾ മരിക്കുന്നുള്ള കാര്യം എനിക്കറിയാം. അതിൻ്റെ സമയം നടക്കട്ടെ. നമ്മൾ അത്രയും അതിനെ പറ്റി കൂടുതൽ അടിച്ച് ടെൻഷൻ അടിക്കേണ്ട ആവശ്യമില്ല എന്നാണ് ഞാൻ വിചാരിക്കും.
In general, when we talk about death and dying and people who come to the palliative care clinic, for example, still there is what we call conspiracy of silence. Everyone knows that they're going to die, like the person's going to soon die, but the conversations are always around bills or medical tests or how the drug is showing. Somehow the conversation around death per se doesn't come out so easily.
A Lancet Commission on the Value of Death published its report, and this international group of experts agreed precisely with this thing, and they said, bring death back to life. Death is not a stranger to be feared and fought at all times.
People should start thinking about, okay, what are the things that I want to avoid? What are the things that I want to happen? How should I die? What should be the funeral like? What are my last wishes? What are the things that I want to complete?
Advanced care planning is an umbrella term. It encompasses everything to do about your wishes towards the end of life. So it would include obviously an advanced medical directive. It would include the appointment of a healthcare proxy or a official designated surrogate for yourself. Then it would include do not attempt resuscitation orders. So there are people who put that down.
When the game is up and you know it, and yet you keep going, yet you keep on escalating interventions, and you are unmindful of the economic and the emotional costs, you are actually not friendly, right? You are doing those things to the patient which are actually doing more harm than good. There needs a paradigm shift.
In 2018, the Supreme Court of India, in a landmark judgment, Common Cause versus Union of India, laid down key legal principles relating to end-of-life care and palliative care. These principles gave effect to the ideas of autonomy, privacy, and dignity in death.
Over the last many years, we have been working in trying to get people to understand what end-of-life care is. The previous judgments of the Supreme Court, which required a person, for withdrawing life support treatment, one had to go to the High Court. I'm happy to say that the recent judgment a couple of years ago has made things much, much easier.
There are 3 things that are important to remember. First, the court held that adult patients who have the capacity to take decisions about their own health care can refuse life-sustaining treatment. Second, even amongst persons who have lost the ability to take decisions, life-sustaining treatment can be withheld or withdrawn when it is in their best interests and is no longer beneficial to them. And third, advanced medical directives, which are more popularly known as living wills, are legally valid documents, and the court laid down a process by which to operationalize these directives as well as to withhold or withdraw life-sustaining treatment.
Advanced directives are really great for people who are queer, neurodivergent, who have mental illnesses. Making healthcare attorney or having the agency to say this is what I want or this I don't want for my body and myself, that's a real powerful thing that we need to really tap into.
The law is only one piece of the puzzle. Palliative care must be viewed holistically and integrated into our social structures and our healthcare delivery system.
So everybody comes and we talk to them, and what we have realized that most of the time family members already they are knowing about that there is nothing going to happen further with the treatment and my patient is in the end stage. They understand already. Only thing they wanted to listen from the doctors, and which we do.
You can see the dying is not a medical issue. It has a medical component, but it is largely a social, personal, spiritual, emotional issue. So the hospital may not be the right place to address this. So that who else can involve? So a lot of people in the community, like there are who is the best people in the community to address the spiritual issue, who is the best people in the neighborhood to address emotional issues, who can offer companionship, who can address social issues. So there's a huge potential there.
And another hospital means their doctors, I feel that doctors may not tell the truth to the patient because they will give the hope. Even the last moment or we know that the patient will not stay much longer, but still they continue all the diagnostic procedures and they give the trust to the patient. But here I have seen the doctors and counselors take a special interest and talk with the patient relatives and their family members. They have to prepare the patient, prepare the family members to accept the fact because that a few days that patient will be no more.
രോഗിയെ പരിചരിക്കുന്ന ആൾക്കാർക്കും ധാരാളം ബുദ്ധിമുട്ടുകളുണ്ടാവും. അവരുടെ ഭാഗത്ത് നിന്നുകൊണ്ടും കൂടിയും ചിന്തിച്ച് അവരുടെ പ്രശ്നങ്ങളും അവരുടെ ശാരീരിക മാനസിക ബുദ്ധിമുട്ടുകളും എന്തൊക്കെയാണെന്ന് മനസ്സിലാക്കുകയും അവർക്ക് ഈ കിടപ്പിലായി പോയ രോഗീനെ എങ്ങനെ വീട്ടിൽ വെച്ച് പരിചരിക്കാൻ പറ്റും എന്നുള്ളത് അവരെ ട്രെയിൻ ചെയ്യിപ്പിക്കുക എന്നുള്ളതാണ് നമ്മുടെ പ്രധാന ഉദ്ദേശം.
There is a more exploratory process where they try and understand about who they are as people to begin with, what are some of the things they understand about their illness, the treatment they've done so far, and then move into understanding, how they are coping, what are the things they're really struggling with, right? What are the psychological things in terms of practical difficulties that caregivers might experience? What are some of the things that they can do?
The focus earlier was on developing few volunteers for the palliative care clinics. But what we need is that this to be, developed as a basic life skill that everybody knows.
You should be looking at whether you're doing a good job as a doctor. Okay, if you did a good job, I don't think you would infringe on any law. I think law is secondary. Law must come from practice, not the other way around.
I don't want my doctor to ever put me on a ventilator, even if this means that I will die. How can I ensure this? My father has dementia and he's put me in charge of his treatment decisions. How do I know what the right course of action is? I don't think my patient is benefiting from a ventilator. Can I take him off it? Will I be sued? If you are a patient, a caregiver, or a healthcare worker and have struggled with answers to these questions, this toolkit is to help you. We have put together a set of resources, frequently asked questions, a model advance directive, a guide for hospitals to help them observe the guidelines in the Supreme Court's order, as well as a ready reckoner to answer any questions that you might have around death, dying, advanced care planning, advanced medical directives, palliative care, and end of life.